Hello, I'm Dr. Tim Gardner. We're here at American Heart Association Scientific Sessions. We're going to talk about the session this morning on management of cardiovascular disease. I have with me one of the presenters at this morning's session, Dr. Mikhail Kosiborod from Kansas City. And it was an interesting session. We sort of covered a bunch of topics. Why don't we start with give me your impressions of that first paper by the cardiologist from Australia about enhanced management of patients at home, patients with chronic atrial fibrillation.
Yes, no, so it was an admirable effort, I thought, and the study was well done methodologically. Of course, disease management programs like this, have always had, we've had very high hopes that they will improve outcomes in a variety of patient populations with chronic disease, including heart failure and atrial fibrillation, certainly one of them. And I think the study clearly demonstrates some of the challenges in disease management programs. Really, we've seen mixed results, and we've seen it in heart failure, and we're certainly seeing with atrial fibrillation as well, where the intervention clearly was well-intentioned, the trial was well done. The results probably weren't quite as positive as we would like for them to be. Overall, it was a relatively neutral study. So again, just to me, it highlights the fact that at least from a randomized trial standpoint, it doesn't seem like there is a definite win for disease management programs just yet across this patient, disease conditions. It's kind of a mixed bag.
Yeah, I think it was rather disappointing, the outcomes, especially if you look at cost effectiveness. I mean, their intervention was a nurse actually in the home, and that didn't seem to make a dramatic difference as we might have expected.
Right.
Go ahead.
No, I was just going to say one of these things is, I think what the presenter alluded to, which is the more you look, the more you find, is one possible explanation for that. We've seen it in some of the heart failure studies, which is if you follow patients very, very carefully, you may end up finding more symptoms, and some of that may drive more hospitalizations. Who knows? But it certainly could be one of the explanations.
Yeah. There was another interesting paper presented from Japan, was sort of talking about triple therapy with olmesartan for patients with, I think they were targeting patients with heart failure and preserved ejection fraction, but actually it was a bit of a mixed group.
Right.
And again, a bit of a negative study, maybe even a not so good outcome.
Yeah, no, I mean, it's the combination of ACE inhibitors and ARBs, of course, that was over a number of years, the hope in a variety of conditions. One was heart failure and certainly hypertension. And we've kind of seen more recently, study after study, probably as far as large studies are concerned, Altitude was the one a couple of years ago that was negative in patients with diabetes. And the same kind of signal, increased renal dysfunction, more hyperkalemia, more hypotension. I think what the study shows is that adding angiotensin receptor blockers to this well-managed patients with heart failure, certainly those that are already on the ACE inhibitor for sure, doesn't seem to add any benefit and may be associated with worse outcomes, particularly when you look at renal dysfunction, which I think was one of the main safety issues they found.
Yeah, Eric Velasquez from Duke was the discussant, pointed out that maybe the population wasn't quite what we see here in the States, more male-dominated patients who were already had hypertension pretty well controlled. But at any rate, somewhat disappointing study as well.
Right, and then of course one of the other things that we frequently see, and what Altitude and other previous studies have shown, and I think that's one of the questions the discussant asked, was the rates of hyperkalemia. So of course when you double on angiotensin receptor blockers adding to ACE inhibitors, the rates of hyperkalemia can go up as well.
Right. I want to get to your very exciting study, but just a comment about the two presentations about novel oral anticoagulation. Obviously the big issue with those drugs is how to reverse them acutely.
Right.
And I thought we got some insights.
Yes, no, clearly the nice thing to see was that the field is moving forward, and that there are a number of investigations going on to try to address this clear need, which we all recognize. We have these agents which are highly effective in preventing stroke in the setting of atrial fibrillation, but what happens when a patient has life-threatening hemorrhage? How do we reverse it?
Absolutely.
And so it's highly clinically relevant.
Absolutely. My trauma surgeon friends, my cardiac surgery friends, in fact, my surgeon friends in general are unhappy about not being able to deal with this in the acute situation. So there does seem to be, I was impressed with the level of sophistication of the work that's being done, and I think we're going to we're going to find some solutions to this reversal issue.
Right.
Monitoring and reversal issue.
No, it looks promising. I agree. I think it's exciting that the studies are going on. They're still relatively small. At least one of them was in healthy volunteers. So we're going to need to see, bigger studies in more relevant, patient populations. But it's looking promising.
So I want to really concentrate on your presentation, which I thought was the most important of the morning. It was certainly a positive, a new innovation in the management of hyperkalemia. I come from the era of K-exolate, and we're looking to go beyond that, but I haven't seen anything much on the horizon until I heard your presentation this morning about ZS. What's ZS?
Well, thank you, first of all, and it is very exciting. In fact, we have not had anything. K-exolate has been around for decades, and we're very much used to using it, and we know what it's about. But when you actually look at the efficacy, we don't really know what the efficacy is.
Plus, it's not really an option for outpatients.
It's not an option outpatients, not a good option anyway,
yeah,
predominantly because it's not well tolerated.
Yes.
And the efficacy is questionable because there are no controlled randomized trials. And there have been many, many reports of real serious gastrointestinal toxicity, some cases, in fact, fatal gastrointestinal toxicity. And so it's an issue, and we need
all right, so that sets us up for the ZS. Tell us about ZS.
So ZS is a completely novel first-in-class compound. It's an inorganic zirconium cyclosilicate crystal, and the crystal structure is actually extremely has very high affinity and selectivity for potassium. So it's actually more than 125 times more selective for potassium trapping than K-exolate is, and because it's highly selective for potassium, it can start binding potassium, pretty much throughout the gastrointestinal tract. In fact, it can start trapping potassium in foods that you consume, and so it doesn't need to. We don't need to wait till it gets to the colon, which is how K-exolate works.
Right.
You don't have to wait for that, and that's why it takes a while for K-exolate to actually work. Where this particular compound, what we demonstrated in trials, that started working within an hour of administration, which is quite remarkable.
So what is it substitutes what? I mean, you get sodium and hydrogen.
Yes. So it exchanges potassium for sodium and hydrogen, and one of the things that of course has come up is, well, if it exchanges potassium for sodium, is it possible that you quote unquote sodium loading the patient, and in patients with heart failure, who of course would benefit potentially from this drug that treats hyperkalemia, which is more common in patients with heart failure, particularly heart failure and CKD. What happens with that? Well, we've done very extensive work and actually have demonstrated that the sodium loading doesn't appear to take place.
Right.
No increase in body weight, no increase in blood pressure, no increase in urinary sodium excretion. So that doesn't appear to be an issue.
Right. So that's sort of the safety issues. But what about the efficacy, as you pointed out today in the study?
Yes. So the efficacy was, I guess the bottom line is the drug was highly effective, both in the open label phase, which was the initial 48 hours, where patients actually entered with hyperkalemia that was either mild, moderate, or severe. We've had patients in the study with potassium as high as 7.2 milliequivalents per liter, and within 48 hours, at a dose of 10 grams 3 times daily, the compound was highly effective in lowering potassium. So, in fact, 98% of patients were normal within 48 hours, and the median time to normalization was 2.2 hours. So within just over 2 hours, 50% of patients have normalized the potassium.
Right. It was an interesting study design. Just review that as well.
Sure. So we enrolled patients that were hyperkalemic, so they had to have either history of elevated potassium or laboratory evidence.
And hyperkalemia defined as what level? Minimum level?
The minimum had to be 5.1 milliequivalents per liter or above.
Right.
And about just over half of the patients had either moderate or severe hyperkalemia, so that's potassium either above 5.5 to 6 or over 6. And as I said, some of them were as high as 7 or even more than 7. And so for the first 48 hours, these patients were treated open label, so everybody got 10 grams of ZS 3 times daily for 48 hours. And then those patients with potassium normalized, which was the overwhelming majority, were then randomized to 3 doses of ZS, 5, 10, or 15 grams, or matching placebo once daily, and then they were treated for 4 weeks.
Right.
And again, the open label phase results I just covered, which is immediate reduction in potassium levels, that was significant within 1 hour. 50% of patients were normal by just over 2 hours. 84% normal by 24 hours and 98% by 48 hours.
So you talked about potassium hydrogen exchange. Is acidosis, or is there a problem there? Any problem with proton load?
No, and in fact, when you look at that randomized phase, we treat patients for up to 4 weeks, so we had quite a bit of time to look at these patients, and these potassium-lowering effects that I just mentioned were maintained over the entire 4-week period of time, which was the primary endpoint. But when we, as far as exchanging potassium for hydrogen, it does not appear to be an issue at all in terms of the acid base. There is certainly no evidence of acidosis. So we looked at the urinary pH, and we actually looked at the serum bicarbonate levels. And both the urinary pH and the serum bicarbonate levels actually went up.
Wow.
So there was absolutely no evidence that release of hydrogen causes any acid base on the acid side. There is no acidosis signal whatsoever.
Great. The one thing you mentioned in the high dose, the highest dose, there was some edema.
Right.
You also mentioned there was not weight gain. So what's the mechanism for the edema, and is that a signal that there might be fluid retention that you didn't pick up on the body weight?
So again, as you mentioned, no body weight, no blood pressure change, no urinary sodium, so it doesn't appear to be a sodium-related issue. There was only one group of patients that developed more edema numerically, which was the patients on the highest dose of 15 grams. And that was the group that actually had higher baseline prevalence of heart failure, and also higher brain natriuretic peptide levels at baseline. And it was a play of chance because the study was about 250 patients in total. There were, by chance, some mismatches between the 4 groups. And in my opinion, I think that's the most likely explanation for why we ended up seeing higher prevalence of edema in the 15-gram dose group. Overwhelming majority of patients that developed edema in the study, regardless of which group they were allocated to, about 14 patients in total across all 4 groups, had mild peripheral edema, and 13 out of 14 successfully completed the study. We have since looked very carefully at the long-term extension studies that we currently have ongoing to make sure that this edema signal is not a real signal. And what we're seeing so far with over 6,200 patient-day exposure on various doses of ZS, we see that the rates of edema are actually lower than what we saw with placebo in the harmonized trials that we presented today. So it all's looking favorable.
Great. Now, this was a phase 3 trial?
Phase 3, yes.
So where do you stand? Is there a CE mark application or FDA, NDA? Where do you stand with
Right. So there are, as I said, we have 2 ongoing long-term safety studies, which was something that is going to be a part of that application, of course. But the ZS Pharma, which is the company that produces ZS, is working on putting the regulatory submission package. So obviously, the ultimate plan is to submit it for regulatory approval.
In both Europe and US?
Yes.
Great. Well, that was an exciting presentation. I know you have it published in JAMA.
Yes, it came out this morning, yes.
So that was, as I said, an excellent presentation, an interesting session, some pragmatic sort of research, and then some new ideas, new innovations, and a very good session. So thank you very much.
My pleasure.
And greetings here again from American Heart Association Scientific Sessions. Thank you.